This is Roy Stroud, neuro-oncologist at Wake Forest School of Medicine and co-director of the Neurofibromatosis and Tuberous Sclerosis Clinics. And on behalf of myself and Dr. Jayshree Blakely, director of the Comprehensive Neurofibromatosis Center at Johns Hopkins Hospital, we're delighted to present this chapter on genetic syndromes of brain tumors. At the end of this presentation, you should be able to describe the diagnostic criteria and typical manifestations for the following neurogenetic syndromes, including neurofibromatosis type 1, type 2, and tuberous sclerosis. In the chapter, we review von Hippel-Lindau, Li-Fraumeni, and Cowden disease, though in the presentation we'll focus on the most common, the top 3 of these neurogenetic syndromes. You should also be able to diagnose and manage the common brain tumors that occur in patients with these syndromes. When we think about these syndromes, they fall into the bucket of conditions known as the phacomatoses. This is a group of autosomal dominant, inherited conditions characterized by manifestations on the skin, the nervous system, and a predisposition to tumors, amongst other manifestations. These are the prototypical tumor suppressor syndromes, and they're characterized by an abnormality, a mutation, in a tumor suppressor gene. There are a number of syndromes that we think about, and the chapter goes into great detail of a number of these, and here in this presentation, we'll focus on the first 3, the most common, NF1, NF2, and tuberous sclerosis. So let's start with NF1, and we'll walk through some of the cutaneous manifestations, nervous system manifestations, tumors that occur in these syndromes, and discuss the management of those. NF1 is one of the most common neurogenetic conditions, affecting 1 in about 3,000 live births. It is a genetic condition that is inherited in an autosomal dominant fashion, though about 50% of patients will acquire the NF1 mutation de novo at the time of conception and not have an underlying family history. It results from mutation in the NF1 gene, which is one of the largest genes in the human genome, and can result in any number of point mutations, partial alterations, or large gene microdeletions. These microdeletions can predispose to a particularly severe form of the disease. When we think about the clinical manifestations, there are 2 important underlying genetic principles that can help explain the typical manifestations. The first is loss of heterozygosity, in which the underlying germline mutation leads to heterozygosity at the NF1 allele. When patients randomly acquire mutation of the remaining intact NF1 allele, tumor formation occurs, and this contributes to many of the major manifestations of the disease. At the same time, in the surrounding tissues, which are heterozygous at the NF1 allele, symptoms may also develop as a result of something called haploinsufficiency, or the inability to maintain normal cell function with only 1 intact NF1 allele, and this contributes to some of the minor manifestations of the disease. NF1 is diagnosed clinically, and while there is genetic testing, due to the large size of the gene and the many mutational events that can contribute to this syndrome, the clinical diagnosis remains the gold standard. When we think about the NIH diagnostic criteria, there are 7 criterion that contribute to the diagnosis, and patients can be given the clinical diagnosis when 2 or more of the following are met. Number 1, 6 or more cafe au lait macules. And we can see a typical hyperpigmented flat macular lesion on the skin here in the upper left portion of the image. 6 or more of these contribute to a clinical diagnosis and are uncommon sporadically. Greater than 2 neurofibromas or any 1 plexiform neurofibroma, axillary or inguinal freckling, which is seen here on the figure to the right, the presence of an optic pathway glioma, greater than 2 Lisch nodules, hyperpigmented lesions on the iris of the skin, which can be detected either by bedside clinical examination or slit lamp examination by a neuro-ophthalmologist. Distinct osseous lesions, and 2 are considered diagnostic of NF1. The first is sphenoid wing dysplasia, which can be seen here, this hyperostosis and dysplastic bony formation of the sphenoid wing, or thinning of the long bone cortex with or without pseudoarthrosis, a pseudojoint, which is common in the long bones of the leg, the femur, being a prototypical bone. And then the last is a family history, which is considered diagnostic if present in a first-degree relative, a parent, sibling, or offspring. There are a few clinical pearls that we would like to highlight in this presentation, and while the subsequent slides will focus on common NF1-associated brain tumors and their treatment options, First, let's consider the child presenting with an abnormal MRI and multiple cafe-au-lait macules. One or more cafe-au-lait macules occurs in about 10% of the general population and is not uncommon and does not establish a diagnosis of NF1. Children with 3 to 5 cafe-au-lait macules should be evaluated by a trained specialist, either a dermatologist or geneticist familiar with NF1, as they could have a mosaic form of NF1 where only a portion of the body is involved, or another cafe-au-lait macule syndrome, those which are summarized in the table to the right here. Children with 6 or more cafe-au-lait macules are highly likely to develop a second manifestation of NF1 and meet the diagnostic criterion, but if not present, this should also raise caution about an alternative diagnosis. So what are the common brain findings that we see in NF1? Well, it's not uncommon for us to see a normal MRI of the brain in a patient with otherwise diagnostic cutaneous stigmata. And we can see here on the upper left an axial image from a FLAIR sequence of an MRI of the brain showing several underlying subcutaneous neurofibromas in an otherwise unremarkable MRI of the brain. At the same time, and particularly in children with NF1, it's common to see areas of high signal intensity in the subcortical gray matter or cerebellum. These so-called focal areas of signal intensity, or FACI lesions, are characteristic of NF1 and were previously termed UBOs, or unidentified bright objects. You can see a representative FLAIR sequence from this axial MRI on the upper right, and on the bottom we see that these lesions improve or resolve over time. In this patient who at the age of 2 had a clear and obvious lesion in the right cerebellar hemisphere, which nearly resolved by the age of 16. These lesions do not have a propensity to grow, they do not enhance with gadolinium contrast, and are otherwise asymptomatic on clinical exam, and require neither biopsy, resection, or treatment. Those lesions that do require evaluation and at times treatment include optic pathway gliomas and extraoptic gliomas, which we'll review in the next couple of slides. Optic pathway gliomas are the most common brain tumor that occur in patients with NF1. About 15 to 20% of NF1 patients will develop a brain tumor, and 70% of these are optic pathway gliomas. The remainder are extraoptic lesions, which we'll review on the next slide. Optic pathway gliomas are typically WHO grade 1 pilocytic astrocytomas that occur in the optic nerve, chiasm, and less commonly the optic radiations. And we see here on the right several representative images showing contrast enhancing T1 hypointense, T2 hyper to isointense lesions involving the optic nerve and extending back to and or involving the optic chiasm. NF1 children who are less than 2 years old at the onset of symptomatic OPG are female sex or have imaging evidence of involvement of those optic radiations are at higher risk of symptomatic progression and poor prognosis. But in general, studies suggest that about a third of patients with optic pathway gliomas in NF1 will not show clinical or imaging progression and are frequently monitored with yearly eye exams and intermittent imaging without requiring treatment. About a third of patients with optic pathway gliomas will show some evidence of progression, either by ophthalmologic exam or MRI, but will not require treatment. And the remaining third will require treatment, which typically involves first-line chemotherapy. Indications for treatment include vision loss on serial surveillance exams, exophthalmos or precocious puberty, and should be monitored closely by a multidisciplinary team. Extraoptic gliomas also occur but are less common. You can see here in the schematic image on the top right that the vast majority of NF1-associated brain tumors occur in the optic pathway, with the remaining 17% occurring in the brainstem, 4% in the cerebellum, 12% in the cortex and subcortical gray matter, and rarely in the spinal cord. In general, outcomes for all these tumors tend to be more favorable than those that are found in sporadically occurring gliomas. In patients with progressive lesions by imaging or clinical exam, biopsy may be required. We tend to watch these patients with imaging, and with rapidly progressive growth, new contrast enhancement, or clinical symptoms will pursue biopsy or resection as able. We see in the table on the bottom right that in pediatric NF1 patients, the majority of tumors are optic pathway gliomas, are low grade, and are associated with more favorable outcomes even without treatment. Even in children with high grade NF1-associated gliomas outcomes with treatment are better than non-NF1 patients with the same tumor type. In NF1 adults, progressively enlarging or symptomatic brain tumors are quite rare. When this does occur, studies are mixed on the prognostic implications, though again in general outcomes are more favorable. Studies support more favorable outcomes in the treatment of NF1-associated GBM, which typically follows the same treatment recommendations as we would see with non-NF1-associated GBM. Progressive low-grade lesions are uncommon in adults and often favorable, though progressive extraoptic pilocytic astrocytomas may have a worse outcome than expected. So what do we do in terms of surveillance and management of optic pathway gliomas? Well, as you can see here, surveillance recommendations for optic pathway gliomas include a yearly eye exam until the age of 8, then transitioning to about every other year between 8 and 18, and then in adulthood every other year, then monitoring for cataracts and glaucoma as opposed to optic pathway gliomas, which is at a peak concern up until the age of 12 to 13, early adolescence. There's really no consensus recommendation for the use of prophylactic MRI brain to survey patients with NF1, though consensus recommendation is for MRI of the brain in orbits in NF1 patients who show an abnormal eye examination to monitor for underlying optic pathway gliomas. From a management standpoint, the management of progressive symptomatic optic pathway gliomas typically begins with chemotherapy, often with carboplatin with or without vincristine. Radiation is associated with an increased risk of malignant peripheral nerve sheath tumors, a malignant sarcoma, and other secondary malignancies, and is avoided in patients when it can be. Clinical trials are ongoing evaluating targeting agents, including the MEK inhibitors, which may show promise in treating these tumors in the future, but currently chemotherapy is often the first line. What's on the horizon for NF1? Over the last decade, we've seen a number of studies looking at targeted therapies that really attack the underlying NF pathway, RAS, RAF, MEK, mTOR pathway that contribute to tumor formation in these patients. And while this is not specific to brain tumor formation, is relevant for understanding where our field may be headed in the future. Here we see a summary of the study published by a group of investigators, NF investigators, in the New England Journal of Medicine in 2016. This is a phase 1/2 study of selumetinib, selective MEK inhibitor for progressive plexiform neurofibromas in children ages 3 to 18 with progressive inoperable plexiform neurofibromas. These patients were treated with selumetinib twice a day, with the primary outcome being the maximally tolerated dose, and then exploring efficacy, which we see down at the bottom. This agent, again, is a selective MEK inhibitor. This study enrolled 24 patients. The drug was very tolerable with expected side effect profile and adverse events, and with a substantial response rate. And here we see 71% of patients showed a partial response rate, which was defined as a 20% reduction in the size of the plexiform neurofibromas. All patients showed a reduction in the size of the tumor, again with 70% reaching that targeted 20% reduction, sufficient for radiographic response. And we see here in the far right a representative example, both imaging and with photographs of dramatic reduction of a plexiform neurofibroma involving the left thigh. And again, though this is not specific to brain tumors, really highlights some of the development in this field of exploring targeted therapies for the management of tumors associated with NF1. So now let's move on to NF2, the second of the common neurogenetic syndromes characterized by tumors primarily in the brain and spinal cord, and we'll remind ourselves about the common vestibular schwannomas, multiple meningiomas, and spinal ependymomas that are characteristic of this condition. NF2 is not as common as NF1. It affects somewhere about 1 in every 50,000 live births. Again, it is genetic and follows an autosomal dominant inheritance pattern, though about 50% of patients will acquire the mutation de novo and not have a family history of the disease. The mutation occurs in the NF2 gene, which encodes the protein merlin or schwannomin, and again, this gene is located on chromosome 22, which you can see here in the bottom right. NF2, like NF1, shows complete penetrance, so all patients who have the underlying mutational event will have some expression of the disease, though there is variable expressivity, with some patients having very severe burden of disease and others having a milder clinical burden of disease, which cannot be readily predicted by the underlying genotype. The primary manifestations of NF2 are tumors involving the brain or spinal cord or peripheral nerves and include vestibular schwannomas, intracranial meningiomas, and spinal ependymomas. Patients can also develop other tumors, including other spinal schwannomas and posterior subcapsular cataracts, which are cataracts that are, instead of being on the anterior chamber of the lens, on the posterior chamber of the lens, which is less common than the sporadically occurring cataracts that we would see with aging. Schwannomas in this condition are histopathologically characterized by regions of Antoni A and Antoni B regions, which are characteristic and diagnostic histopathologic markers of these tumors. And again, like NF1, the diagnosis of NF2 is established based on clinical criteria, which are summarized here. The vast majority of patients are diagnosed based on the presence of bilateral vestibular schwannomas, which is pathognomonic for this condition. In addition, patients can meet the diagnostic criteria based on a family history of NF2 and several other underlying tumors that are consistent with this condition, or a unilateral vestibular schwannoma and 2 other tumors. Additional findings that can be present in these patients include cutaneous lesions, which are less common in NF1 but can occur. Neurofibromas can occur. Those schwannomas are the prototypical peripheral nerve sheath tumor of this condition. Neuropathy tends to be a little bit more common in NF2 than in F1, and we can see a number of other symptoms that develop as a result of the presence and location of underlying spinal schwannomas. Vestibular schwannomas are really the prototypical tumor seen in this syndrome. They're often bilateral, though unilateral vestibular schwannomas can occur. They appear on contrast-enhanced MRI scans as these gadolinium-enhancing lesions within the internal auditory canal or extending into the CP angle. Common symptoms that herald the presence of an underlying vestibular schwannoma include sensorineural hearing loss, tinnitus or imbalance. Vertigo is really less common with vestibular schwannomas in NF2 than would be seen with other lesions of the vestibular nerve. Typical testing and screening that is performed in these patients include MRI with and without contrast, typically with fine cuts through the internal auditory canal or skull base to resolve small lesions within the IAC. Audiometry is the primary mechanism for evaluating hearing and hearing function in these patients, and typically involves both pure tone average and word recognition scores to survey and evaluate the functional loss associated with these tumors. In addition to vestibular schwannomas, intracranial meningiomas are also characteristic of this syndrome. Unlike classic sporadic meningiomas, which are discrete nodular lesions within the dura, NF2-associated meningiomas are often multiple, can involve both the convexity as well as be intraventricular. And you can see here in the coronal post-contrast gadolinium-enhanced MRI, diffuse thickening of the dura or meningiomatosis. This can be particularly problematic for determining which lesion may be symptomatic in these patients with multiple lesions that cannot all be surgically resected, and patients benefit from consultation with a multidisciplinary team familiar with the evaluation and management of these tumors in NF2 patients. And the third prototypical tumor in this syndrome are spinal ependymomas. These are intramedullary enhancing tumors within the spinal cord. Multiple ependymomas are present in about 58% of NF2 patients with an ependymoma, and the most common site, as you can see here, is the cervicomedullary junction. Again, there's a different natural history of NF2-associated spinal ependymomas compared to sporadic ependymomas. These tumors tend to follow a more indolent course, with the majority of patients being asymptomatic. Symptomatic progression is uncommon and should prompt evaluation with either biopsy and/or resection. How do we treat NF2-associated tumors? When we think about treatment, we're often focusing on 2 tumors: progressive meningiomas, which are usually evidenced on surveillance imaging, or vestibular schwannomas, which can grow on imaging or result in progressive hearing loss, balance dysfunction from compression of the brainstem, or other associated deficits. Typically, patients are surveyed with audiometry every 6 months, brain MRI annually, and spinal imaging every 2 to 3 years, as indicated by the underlying tumor burden. For vestibular schwannomas, surgery has been the backbone of treatment, but can be challenging in patients with bilateral disease where hearing preservation is critical. Radiation is a standard treatment option for sporadic vestibular schwannomas, but has a lower 3- and 5-year control rate in NF2-associated vestibular schwannomas compared to sporadic tumors, where only about 40% of NF2 patients will retain pre-radiation hearing at 3 years. Recently, pharmacologic options are available for the treatment of progressive vestibular schwannomas in NF2, and we'll review this on the subsequent slides. For meningiomas, few pharmacologic options are available, and really surgical resection and stereotactic radiation are standard treatment options for these patients. Care should be taken to correlate the presence of new symptoms with growth on imaging, as treatment of all tumors is not necessarily necessary or beneficial. Critical to the treatment is the consideration of the functional impact of this syndrome and the quality of life of these patients. Symptomatic treatments to preserve and improve hearing, swallowing, facial nerve function, and other symptoms are critical and is best performed by a team who specializes in this condition. In the next few slides, we'll review some of the targeted agents that have been studied for the treatment of progressive vestibular schwannomas in NF2. We'll start with some of the initial agents that were explored and end with a discussion of bevacizumab, one of the more commonly used agents for treatment of these patients. Here we see data from neuro-oncology in 2012. This was a phase 2 study of lapatinib, an oral EGFR inhibitor for the treatment of progressive vestibular schwannomas. This oral agent was given for 12 months with a primary outcome of radiographic response with an acceptable tolerability profile, and in 21 patients, they saw a response rate of about 24%. Everolimus was the second study to be published, again neuro-oncology in 2014. This is a phase 2 study of the oral mTOR inhibitor everolimus. mTOR is a downstream target in this RAS-RAF pathway mediated by the tumor suppressor NF1. And again, this study was in NF2 patients who had progressive vestibular schwannomas, both pediatric and adult patients, treated for 12 months with the primary outcome being radiographic response. No objective responses were observed in this study. 4 patients did achieve a partial response that did not meet the criteria for an objective response. And while these initial studies were intriguing, we really didn't see a change in clinical practice until the publication of bevacizumab for progressive vestibular schwannomas, initially with a paper in the New England Journal in 2009, and the most recent publication in JCO in 2016. There have been 2 phase 2 studies to evaluate bevacizumab for the treatment of progressive vestibular schwannomas. The first evaluated a dose of 5 milligrams per kilogram every 2 weeks, and the subsequent study 7.5 mg per kg every 3. Both studies looked at pediatric and adult patients with progressive vestibular schwannomas evaluating radiographic response and hearing response. Again, bevacizumab is an intravenous VEGF inhibitor, and it tends to be in both of these studies, we see a radiographic response rate, an objective response, a reduction in tumor size by 20% in about 50% of patients. Importantly, we also see improvement in hearing, and here we're looking at word recognition scores. This is 0 words out of 100 and 100 words recognized out of 100, and it tends to be that we see about 50% of patients achieve improvement in hearing from poor hearing initially to an improvement at the end of the 12-month duration of study treatment. And this drug has really changed clinical practice, and we see increasing use and utilization of bevacizumab for the treatment of progressive vestibular schwannomas, both for hearing preservation, hearing improvement, and imaging response. And finally, we'll turn to the last of our 3 syndromes, tuberous sclerosis, again an autosomal dominant neurocutaneous syndrome characterized by cutaneous manifestations, which are summarized here on the left, and nervous system involvement, including brain tumors, which are summarized on the right and we'll review in the subsequent slides. Tuberous sclerosis is the second most common of the neurogenetic conditions we're reviewing here today. Like NF1 and NF2, it is autosomal dominantly inherited, resulting from mutations in the TSC1 or TSC2 genes, which encode proteins hamartin or tuberin. Defects in these tumor suppressor genes predispose to hamartoma formation in the skin, brain, heart, kidney, and other organs. And again, like these other conditions, this follows a 2-hit hypothesis, where the initial germline mutation is the first hit, and predisposes patients to acquiring a second hit or loss of that remaining intact TSC allele, which contributes to tumor formation. Tuberin and hamartin are proteins that normally activate a cell stop signal in the mammalian target of rapamycin cell proliferation pathway, and this is really one of the prototypical syndromes for the function of mTOR and mTOR inhibitors, as we'll talk about at the end. On the right-hand side of this slide, we see some of the typical cutaneous manifestations of tuberous sclerosis. Here, these hypopigmented macules of the skin or ash leaf spots, which are characteristic and make up one of the major manifestations. We see angiofibromas, small hamartomas on the malar region of the face, periungual fibromas, which are hamartoma formation of the around the cuticle of the skin. And here we see a chagrin patch or collagenoma, which is a connective tissue nevus, also characteristic of this condition. Like NF1 and NF2, the diagnosis of tuberous sclerosis is based on clinical criteria, which are reviewed here. A definitive TS diagnosis requires two major criteria, or one major criteria and two minor criteria. A possible TS diagnosis requires one major criteria or two or more minor criteria. And you can see here some of the cutaneous, brain, heart, kidney, lung, and other findings that are typical of these patients, which will be evaluated by a comprehensive multidisciplinary team, including often a dermatologist, neurologist, nephrologist, and other specialists as needed depending on the case. What are the brain findings that we see in TS? This slide highlights the three common CNS manifestations in tuberous sclerosis: cortical tubers, subependymal nodules, and the subependymal giant cell astrocytoma. Cortical tubers are the neuropathologic hallmark of the disease and represent glioneuronal hamartomas or dysplastic neural proliferation that forms during fetal development and may occur in the cortex or subcortex, as you see here. These lesions occur in 90% of TS patients but have no malignant potential, but can contribute to epilepsy, which is extremely common in this condition, or neurocognitive dysfunction. Subependymal nodules are hyperintense lesions adjacent to the ventricular surface that do not enhance with gadolinium contrast. They rarely grow or enlarge, and when enhancement is present, this should raise suspicion for transformation to a SAGA. SAGAs, or subependymal giant cell astrocytomas, are WHO grade 1 tumors that typically occur, as you see here, within the lateral ventricle and often at the foramen of Monro. They can grow over time and may obstruct CSF outflow from the lateral ventricles, resulting in ventriculomegaly or non-communicating hydrocephalus. Surveillance imaging is critical for the evaluation of patients with tuberous sclerosis. The vast majority of these lesions are benign tumors that do not have or possess malignant potential, but can contribute to substantial morbidity and even mortality if growth is not detected early. When thinking about surveillance imaging, each organ system is critical to monitor, and we consider evaluation of dental, neuropsychiatric, neurologic, cardiovascular, pulmonary, renal, dermatologic, and ophthalmologic organ systems. And there are standard guidelines set up for evaluation of the major and minor manifestations that can be seen in these patients, which are highlighted here. What about treatment? How do we treat the CNS manifestations of TS? Of the three nervous system manifestations, cortical tubers and subependymal nodules typically do not grow or require tumor-directed therapy. Cortical tubers, when they contribute to epilepsy, can be amenable to epilepsy surgery evaluation and resection, but many times multiple tumors contribute to epileptogenesis in this condition. SAGAs are monitored every 1 to 3 years with imaging, depending on their growth pattern. Adult TS patients who do not have an underlying SAGA by the age of 25 are very unlikely to newly develop this and often are not monitored into adulthood. Historically, surgical resection endoscopically or through open approach or radiation therapy were the primary treatment modalities for progressive SAGAs in tuberous sclerosis. Increasingly, less invasive surgical treatments, including laser interstitial thermal therapy, have been reported in small series for managing SAGAs, which offer an advantage for accessing the deep location of these tumors. Everolimus is an mTOR inhibitor. It's an oral agent that has demonstrated activity for the treatment of TS-associated tumors. To date, several studies, the EXIST 1, 2, and 3 studies, have reported disease activity against renal AMLs, for treating seizures, and for shrinking SAGAs. Here we see a summary of the phase 2 studies evaluating oral everolimus for TS-associated lesions. This agent is well tolerated with response rates greater than 50% for patients with TS-associated angiomyolipomas, refractory seizures, and SAGAs. And to the right, you see a representative MRI for a patient we treated who had a progressive SAGA, demonstrated here on their baseline pre-everolimus imaging. And after 6 months and then 1 year, we see dramatic shrinkage of this tumor consistent with an objective radiographic response. And again, this type of response has been seen in about 50% of the patients. And so with that, we will leave you with this review of the genetic syndromes of brain tumors with a particular focus on NF1, NF2, and tuberous sclerosis. For additional information, please read our chapter. Thanks so much.